Welcome to our show, COVID Corner. My name is Rosina Rai. Today we have a very special guest. He is Dr. Anup Subedi, Senior Consultant, General Physician. Today we are here to have a conversation about the second wave, COVID second wave. The second wave of the COVID-19 pandemic has hit the country really bad, and there are numerous new cases are there, symptoms that have been brought by the second wave of the pandemic. Furthermore, definitely we are going to put forward the question to Dr. Anup Subedi. Welcome to our show, Dr. Anup Subedi.
Thank you.
Very first, you have very busy schedule, we know that, and first of all, thank you so much for your time. Can you first tell us about second wave, new triple COVID mutation? Can you make more clear about this to the people? Many of us are confused about that.
Mutations are changes in the genetic code of any living organism. That is a very natural process that happens all the time in all kinds of plants and animals and other organisms. Some of these changes give an extra edge to the virus or the organism, makes it more adaptable to the changing environment, and the virus can then survive and pass that genetic code to its progeny, to its offsprings in a way, right? And so that way it is continued in the natural selection process. Whereas if the mutation makes the organism weaker or less adaptable to the surroundings, then that organism dies away, right? And so this is a way for the nature to create more adaptable, more well-established kind of organisms, right? And coronavirus itself is also going through these mutations all the time. And some of those mutations have made the virus more adaptable or more transmissible, or in some ways potentially more virulent, or potentially able to escape our immunity in some ways. And that's why these mutations have persisted in the further generations. And with the accumulation of mutations, the virus is called a variant, a new variant, which is slightly different from the previous version of the virus, right? So, and this is a very common occurrence. There are probably a lot of mutations and a lot of variants in different parts of the world, where people are actually tracking these mutations and tracking the genome sequences of the virus. They have identified some mutations and variants that are of more significant concern. And right now, the one that is most widespread in the world, that is creating the biggest havoc, is the UK variant. And that's the one that is also most widespread in India, and is probably the reason for this second surge in Nepal. So this second wave happened after the first wave had started to slow down significantly, and we can probably assume that most of the parts of the country where it's crowded, where people have been mingling a lot, people had probably reached herd immunity for the older variant, and that's probably why the numbers had started to go down. And in that time, suddenly the UK variant started to emerge. First, it was noticed in United Kingdom, then it spread through United Kingdom, United States, Europe, and India. And we had noticed this variant in Nepal about around 4 months back. That was the time we first checked. If we had checked sooner, we would probably have found it sooner too. So it was spreading in Nepal to some extent, but last month and a half or so, because of the surge in India, there were a lot of migrant workers returning home, and that has created another big influx of infected people coming into the country. And now through the infected people, there has been multiple generations of transmissions in the country itself. So it has been widespread in communities in different parts of the countries. So that's probably what's driving the second wave now.
Nowadays, even family members or colleagues, they say us, please take care of yourself. This time, this second wave is very deadly and deadly cases are happening. So I want to relate in this scenario, how dangerous and infectious is it?
Right. To answer that question correctly, we probably need to know what are the different kinds of variants that are currently circulating in this country. And to do that, we need a kind of a random sampling of several hundred or thousands of viruses, samples in different people, and then do a random sampling and then test them and do the genome sequencing tests and identify the variant types, right? That way, once we know what variants are predominant, we would know what are the specific risks in terms of transmissibility, in terms of virulence associated with those variants, right? But we don't know that. So we can only assume based on what our very limited type of testing showed earlier and what the Indian data are showing. So it looks like, based on those, the UK variant is probably the most predominant. We also have some of the ancestral variant, the wild type variant, also is spreading. The older version of the virus also is spreading to some extent, I'm sure. And so the UK variant is known to be more transmissible. So normally, if you had been able to protect yourself wearing masks, wearing the doing the physical distancing disciplines as much as you could, if you had been able to protect yourself last time, you would have to work harder to protect yourself this time, right? Because it's more transmissible. So if there were some breaches before, maybe there were times when you put down your mask below your nose, right? Several times. Maybe it was excusable at that time. Maybe you still survived it. You didn't get infected. But it's less excusable now. You probably not get that excuse from the virus this time. So you have to be just more careful. You use the word deadly. So the lethality or the fatality risk from a particular variant can be compared. The fatality can be compared between variants, of course, and it has to be understood in two contexts. One is, let's say there is the older variant, there are 100 people infected, and then there's the newer variant, and there are 100 people infected, and you want to see how many of them survived, right? And if the more people die among the 100 people in one group compared to the other, then we say this variant is more deadly, right? More lethal. So in that regards, the UK, it's not clear whether the UK variant is more lethal or not. There were some initial studies that showed that, in a way, at that time everybody believed those studies, that it was thought very clearly suggested that the UK variant is more lethal, right? But recently there were two more studies that were recently published in the last, about 2 weeks back, that suggested maybe they are not more lethal, maybe the lethality is similar. However, so that is one context. So we don't really know whether it's more lethal or not in that way. But there's another way. With equal virulence, a virus can still be more deadly, and that is due to transmissibility. Okay, so the older variant is less transmissible. Let's imagine in the time that a virus spreads from one person to another person, and then from that other person to other person, and so in the time that the virus spreads to 100 people, okay, the UK variant probably spreads to 200 or 250 people. I'm just giving you like random numbers, but it's going to spread to much more people than the older variant. So let's say the mortality was 1% here, so it spread to 100 people, and mortality is 1%, meaning 1% died, right? Here, let's say it spread to 300 people, mortality is still 1%, but now 1% of 300 is 3, right? So 3 people died, 2 more people died during the same time, right? So even though the mortality is the same percent number, more people can die in the more transmissible arm, right? So that's how we should understand. So because it is more transmissible, there will be more deaths. That is inevitable.
You are saying that it is more transmissible. Can you tell us about the severe effects? We normally are understanding it makes a very, again I want to use that word, the deadly symptoms or effects. People are, human body actually are going to get through that condition. So what are the severe effects does it make in human body this time?
Look at the big picture. Infection from the virus can range from completely asymptomatic or without any symptoms, right? Without any way of knowing whether you are sick or not, except by doing a test, to very severe critical illness, right? Where people can die, right? People end up in ICU, can end up in a ventilator and may die, right? So, so there is a big range, big spectrum of the presentation after a person gets the virus. So the proportion of asymptomatic people and proportion of symptomatic people has not been shown to be different compared to the older variant in this UK variants. Okay, it may be different, but large data have not really looked into it maybe very well, and we don't really know that. We don't really know for sure whether there are less asymptomatic people or more asymptomatic people. We don't know that. Similarly, in terms of people who become symptomatic, we don't know if the proportion of more severe cases is higher in one type, one variant compared to the other. Earlier we thought, yes, from the earlier studies, as I mentioned a little bit ago, we thought there would be more severe cases with the UK variant, right? But now the data are a little contradictory, so we don't really know. But again, the same thing, the other context about mortality applies, right? So if 10 to 15% of the people develop severe illness, let's say, of the symptomatic cases, if 10 to 15% of the symptomatic cases develop severe illness, while there are 400 or 500 cases of infection with the older variant, there are already several thousand cases with the newer variant. So even though the same percent of the total, symptomatic cases of, get severe illness, here 10-15% of 500 is, let's say, 50 to 75 total, right? Whereas of 10-15% of 2000 is 200 to 350, for 200 to 300 people, right? So it's a big number, big difference. So a lot more people will be needing intensive care, hospital-based care, oxygen therapy, may need ventilators compared to the older variant. So it doesn't have to be more lethal. Just because it is more transmissible, a lot more people will be sicker, a lot more people will be needing very costly treatment, a lot more people will end up dying, right? And the other thing we need to remember about fatality is that when we say there is 1% mortality, we're talking about mortality when all the needed treatments are available to the person, right? So if somebody needs oxygen, they get oxygen. If somebody needs ICU care, they get ICU care. If somebody needs ventilator, they get the ventilator. And when everything is available, then still one person may die, right? But when you have a surge that leads to 2,000 people needing intensive care or oxygen in one day, let's say, and then you can only provide oxygen to 1,000 people. The other 1,000 are already at risk of dying. So there the mortality is not just going to be 1%. It's going to be much, much higher than that. So that's the scenario we are worried about, because that's what's happening exactly in India. people who could have survived are dying because the numbers are huge.
We have been talking now, second wave, new triple COVID mutations. In this regard, being a doctor, how many variants have been identified so far?
There are, I don't exactly know how many have been listed in the databases that are listing the variants. I don't remember that number. There are probably several hundred at least variants in different parts of the world. However, people look at the variants that are seen more commonly, and which gives you a clue that they probably have some evolutionary edge. They probably have some special characteristics that make people more vulnerable to them. That's why they are in higher numbers in the community, right? So people look at that, either the virulence, the transmissibility, those kind of things, right? And based on the numbers, based on how serious the outbreaks look in different parts of the world, they call them variants of interest, where maybe they are looking at something to see if it becomes more dangerous or if it is something concerning, just to study further, versus variants of concern, where they have already identified that there's something really wrong with this variant that may actually be a threat, a bigger threat, like the UK variant became, right, in the last 6 months. And so there are lots of variants that have been identified. There are at least 10 or 15 variants of concern in different parts of the world. Right now, in the South Asia, in our area, we really don't have the kind of random sampling, randomly sampled, database of genome sequenced cases. So that's the problem. Why we can't really say, but we know that in India and in Bangladesh, in Nepal, the UK variant is the most predominant one right now. In Bangladesh, there is significant number of the South African variant circulating. In India, there is this, in the Maharashtra area and some other pockets of India, there is this the E1617. That's the double mutant, which is a wrong way to name a variant, but again, this is also circulating, and and then there will be more other variants on the way. The Brazilian variant, that's spread in South America and in some parts of North America, and has also been identified in different parts of Asia already. So I wish we had more data from our region to answer that question.
Again, being a senior consultant in this medical sector, how contact tracing could be done?
The definition of contact, the definition of significant exposure for coronavirus, that's what you're trying to understand during contact tracing. What's the level of exposure? The definition of significant exposure is being in a close proximity, mainly within 6 feet, from someone who is known to be infected, okay, and for a total duration of 15 minutes. And that 15 minutes can be cumulative 15 minutes. It doesn't have to be 15 minutes in one setting, in one sitting. You may meet that person, be at a distance of within 6 feet for 3 minutes at one time, and 10 minutes at another time, and 5 more minutes at another time. And if cumulatively you meet 15 minutes together with that person, when that person is infectious, then that's a significant level of contact, right? The other thing is, you have to also understand when that person, the person who is positive now, when that person became contagious, it became infectious to others. And so normally we calculate that time by going back to 48 hours before the onset of their symptoms, or 48 hours before they became PCR positive, okay, depending on whether they were symptomatic or asymptomatic. Okay. So once we keep that in our mind, then we can talk to the individual who is PCR positive, who is now identified as an infected person. We can talk to them and ask whom they met starting from the time that was 48 hours before they had a positive result, or 48 hours before they started having symptoms. How many people they met, what kind of setting was it? Was it outdoors, indoors? Were they more than 6 meters apart? More than 6 feet apart, or less than 6 feet apart? If it is within a closed room, even sitting at 9 feet may still be a significant exposure, right? So, those are the things that matter. Did you hug that person? Did that person actually, cough? So even if your exposure was just 1 minute, but that person coughed right, to your face, you are probably infected, or you are probably exposed, even within that 1 minute. So you have to ask those questions to the person who is identified as a positive case, and then he would say, or she would say, okay, I met these people, or these are my close family members who are exposed to me. And then you talk to them, and then you also try to get information about who else was there. And sometimes the positive person himself or herself may not remember who else was there, but there may be other people who may identify other people. So you just have to keep talking to different people. It doesn't necessarily have to be in person, especially in the time of COVID. You probably do it on the phone most of the time. And so you try to identify as many people as possible who could have been exposed, meeting the definition that I mentioned to you earlier. And then you ask them you call them and say, hey, you are identified as a potential contact. You need to quarantine yourself, for next ideally 14 days. For expediency, for practicality, different countries have made some adjustments to that recommended duration. In the United States, for example, they ask the person contacts to be quarantined for 7 days and get a PCR at the end of 7 days. And if that is negative, they can come out of quarantine. Or if the PCR is not available, ask the person to be quarantined for 10 days total. And if there are no symptoms, the person can come out of quarantine, right? So how is it done? How is contact tracing done? So this is the approach. Either a government agency, the public health department, staff members, they can do it. They can call, the exposed person and get this history and talk to them. Or community volunteers can do it, right? People in the community who can also volunteer to help. Or even, family members or friends can also do it, right? They have to do it for themselves, maybe do it for the other friends' sake, do it to clarify who else was exposed, if their own family members were exposed or not, So there are different groups that can do contact tracing.
These days, you have witnessed the hospital scene properly. So patients who checked in hospital, what different symptoms are identified? The same symptoms in all the patients, similar symptoms or different symptoms, the variants of symptoms who already checked in hospital.
In hospital, people come to the fever clinic with complaints of cough, fever, muscle ache, headache, sore throat. Those are probably the most common symptoms, and then fatigue, right? Some people come with symptoms of not being able to smell things or having no taste of food, and some people can have diarrhea. Okay, these are the usual common presenting symptoms. Apart from that, there are less common presentations too, where people can have clots in different parts of the body and have symptoms accordingly. Sometimes somebody may just collapse, and they may not realize that they were having a low oxygen saturation for some time. They may have been infected for more than a week, and then suddenly they collapse, and then you bring them to the emergency. You suspect COVID, you test, they are positive, you do their x-ray, the x-ray looks like there is a COVID pneumonia, So there may be a big range of presentations, but commonly at the fever clinic, the symptoms that I mentioned are the common ones. And this is not really different from the older variants.
I'm going to ask a question to you. I personally also sometimes think, what if my all family members suffer from COVID-19? They all have that simultaneously. Can we stay together?
So family members who are positive can sit together, can stay together, because they have already been, identified as positive cases. There is no risk of one giving a virus to a unexposed person there, right? So they are all infected already. The tricky part comes in quarantining, basically. So if there are 6 family members and 1 becomes positive and 5 are exposed contacts, right, significant contacts, there the infected person, or let's say 2 people are infected, so the 2 infected people, PCR positive, they can sit together. One of them may recover sooner, one of them may recover later, one of them may keep having fever for 12 days, and so they may need isolation for, let's say, 15 days. The other, gets better and with no symptoms after day 5, and then comes out of isolation at day 10, right? And even those 2, even the person who recovers sooner, they can still sit together. Okay. Yeah, right? That's the infected people. Now, the other 4 people who were exposed but were not having symptoms, we don't test them immediately because of the incubation period. They may have been exposed and the virus may have entered their bodies, but the virus will not show up on a test if you do it now. So the incubation period is 2 to 14 days. So the virus can, show up on PCRs during that time. Like, it may be negative now, but after 10 days it may become positive. And it may, the persons may also have symptoms during that time, after 8 days or after 10 days, right? So it doesn't make sense to test them right away. Now, how do you, they cannot stay together either. The infected people can stay together. The people who are just exposed, they cannot stay together because one person may have got the virus, the others may not. We don't know. And if they stay together, the one person that has already got the virus may start to shed the virus asymptomatically without having any symptoms, and give to the others too, right? So we have to make sure that people who are supposed to be in quarantine in one family, they have to sit separately. They cannot mingle together. So they are the ones who should be most careful in terms of isolating themselves, right? They have to stay separate. They have to wear masks when they are in front of, close to each other, in close proximity. They cannot eat together, lunch or dinner. So that's more tricky. So quarantine is more tricky because everybody has to stay separate. They cannot mingle. Isolation, it's easier in that regards because people can all be together.
What we have seen nowadays is that people are consuming vitamin tablets, vitamin D, and other supplements at their own. And even we do suggest each other, oh, you are having fever and this and that, please have zinc, vitamin D, we send the list of that. What I want to ask is that, many of us are nowadays doing this. We are actually taking these supplements. So is it good, or we should follow some medical protocols while taking these supplements?
No vitamin has been shown to be helpful in COVID. There have been studies on different vitamins, and so far nothing in the range of vitamins and minerals has been shown to be helpful. There is no evidence to support their use when somebody gets infected. And so I see it's a very common question. I see patients every day who are already taking vitamins, and they ask me that, and I basically tell them, if I get sick, I wouldn't take them.
recently I got sick and I was suggested, and I got this list of supplements. You have this, boost your immune and you'll be cured sooner. We people are having this misunderstanding, or this information is out there.
So, and let me point out another point about immunity, because immunity is not something you can just create out of nowhere within 3 or 4 days after starting vitamin supplements. Unfortunately, that's not how it works, right? Immunity is more of a combination of different factors, including, have you been exposed to that virus before? Has your body been, in some way, has your body got to, see this virus before, either the same virus or like a sibling of that virus, or something similar, so that your body can, immune system can retain some memory of it and can mount antibodies response towards against it, right? That's one part. The other is, have you lived a healthy life? Have you eaten healthy? Have you tried to avoid being obese, for example, right? Or have you been smoking cigarettes or not? Have you been drinking a lot, alcohol or not? Those kind of things also affect your immune system. So that's not something you can change overnight by just taking some vitamin supplements. The other is vaccines, right? I see people who didn't take vaccines but are now taking vitamins to boost their immunity, and that is completely counterintuitive.
Definitely, this question, it's very common question probably asked by, but I want to ask is, again, there is people are consuming wrong information or data and this and that. So what type of people or age group are suffer mostly from the second COVID wave?
To really tell you what's the proportion of different age groups infected this time, you would need a more comprehensive data. Okay. In Kathmandu, for example, who goes for testing? It's usually the young people who go for testing, right? Because they can just ride a bike and go to a testing center and give a sample. Elderly people, it's much harder for them to go for testing. One, there's less awareness of the importance of testing, probably, right? And then if even among people who who understand it's important to get tested, there are less easier means of transportation for them. The testing sites are very crowded now, and they cannot wait in line for 2 hours or 3 hours. And so there are so many other obstacles for certain age groups or people with disabilities, people with different comorbidities to visit a testing center and get tested, right? So when we look at the numbers, we have to keep that thing in mind. It seems from the data in India that and actually rest of the world too, that this time around a bit more younger people are getting infected, okay? And but it doesn't mean that the virus is somehow able to attack younger people more than older people. That's not, I believe, how it should be interpreted. It seems that the virus is more transmissible across all age groups. In like Europe, America, a lot of elderly people have been vaccinated. The majority of them have been vaccinated, right, in some countries. And so yes, there you would see younger people who are more infected in bigger numbers, because older people are now immune, right? In Nepal, some segment of the older people have been vaccinated, at least one dose, and that gives them some level of protection. And what happened in the last 5-6 months is that we completely opened up everything, and we just let it remain open for too long a time, including nightclubs, including stadiums, including these big arenas where there are political rallies, or the Prime Minister is giving speeches and there are thousands of people there, So there are these events where a lot of younger people visit, not the older people. There are these schools, nightclubs where just young people go. And so the younger people had a much bigger level of movement to get exposed to that virus. So that's probably why we're seeing bigger numbers of younger people this time around.
Last time we have faced this situation regarding expanding hospital capacities and equip them with medical supplies. And now in this second wave, COVID wave, we people are a little more feared of it. Now in this situation, in this second COVID wave, are we well prepared regarding this all matter I have said before, or and is government of Nepal well prepared for this time, or they are going to repeat the old past experience?
You mean repeat the past mistakes?
Yes.
So, from the looks of things so far, it doesn't seem that there have been enough preparations, adequate preparation. Yes, there have been some attempts at making preparations, or some rituals that have been done, but the challenge is much more enormous this time, and we haven't really risen to the challenge yet, right? So you mentioned hospitals. I should probably point out that hospitals are the last frontiers of the battle against the pandemic, where we are sure to lose. Okay, we will have already lost the battle if that's where we are just fighting the pandemic, because arranging more beds in the hospital, trying to arrange oxygen cylinders and all that means there are just too many people infected already. Yes. Right? So the key is that we have to be better prepared in the community before cases start to spill to the hospital.
In community.
Yeah. So and how do you fight it in the community? It's a very basic, simple concept. Mm-hmm. You try to identify as many people as possible who are either infected or who are at the risk of infection, who are potentially infected. Mm-hmm. So either infected or potentially infected, right? So how do you do that? You do tests. You make tests cheaper, you make tests more available, accessible to everyone. Ideally, we should make the tests free, the PCR tests free for everyone who is symptomatic and everyone who is an exposed contact person, right? And when you do that, you are also following the science, because the virus can be transmitted from an asymptomatic infected person, right? Or it can be, and the test can be negative today but can be positive in 10 days. So you cannot just say, okay, I'm just going to identify the currently infected PCR positive cases. You have to be also able to identify cases who will become positive later, not now. So how do you do that? You test as many people as possible. You do contact tracing. You identify their contacts, and then you ask the contacts to be quarantined, and then test them later, right? And then among the positive cases, you isolate them. You put them in a place where they cannot spread the disease to others. And similarly, you quarantine possible contacts, so potentially exposed people. When you quarantine them, they cannot transmit the virus to others, right? Even though they may be asymptomatic, positive already, right? Or even though they are in pre-symptomatic phase and you haven't really identified them as infected cases, but once you quarantine them, there is no risk of them, transmitting the disease to others. So The key is to try to find as many people who are infected or potentially infected and isolate or quarantine them. So test, trace, isolate, quarantine is the Bible, or is the everything of public health, in cases of outbreak and pandemic. And of course, vaccination. We are in a much difficult situation because it's not within our control. So what's within our control? Test, trace, isolate, quarantine. That is within our control. Okay, we still have a much bigger capacity for testing, and we can actually increase that capacity. We can actually train more people and open more labs. As long as there are cases and as long as there is business, people will be there to provide the tests. And there's a big role for government in trying to ensure that. If the government or different levels of government do contact tracing, they will be able to identify much more bigger pool of infected or potentially infected people. And once you separate them, then the level of infection, the burden of infection in the community starts to go down. Then there will be less spillage to the hospitals. There will be less pressure on the hospitals for oxygen supply, for ICU care, for ventilator care. And that's the only way. Controlling it in the community is the only way to make sure that people die less in hospitals.
Very last query I'm going to put forward to you is that there is communication crisis. What I mean to say is that so many misunderstanding is there. So I'm going to actually relate. So many people they have got vaccinated, second dose already, and they think that I'm not going to be infected, and they are actually working here and there. I think with no being responsible, I have to say, because they think that I have got a vaccine, so I'm not going to be infected again. So what message you want to put forward for those information they are having inside?
That's a very small segment of population, let's keep in mind, right? I mean, what's the percentage of people who got 2 doses of vaccines in this country? Probably less than 1%, I'm not sure. Okay, I don't think 3 lakh healthcare workers got 2 doses yet, right? There are probably 2.5 lakh or less healthcare workers, and then journalists, few other consulate people, right? Frontline workers. So that is really a small percent of the population. But anyway, we have to remember, even after you get the second dose, it takes a few weeks for that second vaccine to give you the boost in your immunity, right? So we are not past that 2-3 week period yet. We are still within that 2 week period, right? Most of the people who got the second shot. The protection from vaccine is not 100%, okay, right? The Oxford AstraZeneca vaccine, their best efficacy seems to be 85 to 89%, at best, in some studies. So that means there is still chance of you having an infection even after the second shot, and that infection can be tricky. While we know that the chance of getting very sick with the second infection, chance of needing ICU or ventilator, or a chance of dying is much almost negligible after the second shot, after a few weeks after the second shot. We know that you can still get infection from the second shot. It may be mild symptoms, or it may be asymptomatic infection, which means you may have the infection, you may not be aware, and you may be giving the virus to your close family members who may not have got the vaccine. Your children, for example, or your parents who may not have got the vaccine, right? Or other family members. And yes, you may survive it, but they may not.
They can be carrier.
Yeah, you can be a carrier, yeah, right? So that's why it's important to keep in mind that while the burden of infection in the community is so high, even if you have been vaccinated, there is still very high risk of you getting at least a mild or asymptomatic infection, because the burden in the community is high. If we had been vaccinated and the burden in the community was very negligible, there was no infection, community transmission, yes, then you could have, you don't need to wear a mask maybe, right? But while the burden in the community is very high, while the burden of, and like 98-99% of the community has not been vaccinated, there is very little cause to say, oh, I'm immune and so I can just do whatever I want.
Thank you so much, Dr. Anup Subedi, sir, for your valuable time. Though you are very busy, I already have said that, and it is wonderful conversation. Thank you so much for watching us. And I would like to take leave. Definitely will be joining back in next episode with another very special guest. Till then, stay safe, be more responsible. Thank you.